it's a real pleasure to be leading this session, which is very kindly sponsored by one of the platinum supporters of this year's EBC, Cordis. And so this has been entitled Keeping Bifurcation Procedures Simple and Safe, the DEB Alternative. If you just put up a couple of introduction slides, there seems to be a kind of irony that we come to the city of marijuana, the city of pot, and yet we're not going to talk anything about the kind of the techniques that we've spent years of our lives sitting in dark rooms kind of arguing about where you place the balloon in relation to the carina and the stent. And what we're looking for now is trying to retain some degree of simplicity. And maybe you just need to smoke pot and just blow up a balloon and everything's good. So the reality is I'm chairing this session, Tom Johnson from Bristol, and we're very lucky to have a couple of great speakers. We have Gábor Tóth from Austria, Graz in Austria, and Abhishek, another UK colleague coming from Wigan. In terms of that dynamic process of how we deal with interventions leaving nothing behind, sadly we've left Simon Eccleshall behind because he's phoned in sick today, so he's no longer able to join us. But we have Beatriz from Spain to offer her insights into the role of DEB, DCB treatment as well. I was in an ad board this morning with Cordis, and they had a flyer, which I don't see, I thought was going to be on the seats, but the real excitement is the fact that Solution De Novo, the most ambitious of trials, which is over 3,000 patients recruited, will be reporting its 12-month data at TCT in later this month. And clearly, that is going to inform us in terms of where we're heading with this exciting technology. But I thought what we're going to do is briefly outline what Solution SLR offers in terms of the technology in comparison to other balloons. We've already heard from Bruno Scheller about this idea of blended or puristic approaches, and we thought what would be nice would be to really engage discussion with you around two cases, one which is a hybrid approach, and the other that will be puristic, and that comes from Abhishek Kumar, who has been leading a study or registry of DEB use in the UK, and he'll give us more detail on that. We've got a very limited time, so I'll hand over to Gábor to take us through the technology in the first case.
Thank you, Tom, and thank you everyone for being here in this session, and thank you for Cordis to support this session. So, when we talk about DCB, I think it's very important to understand that there are numerous devices on the market, but there are fundamental differences between the different tools, and this is why I would like to first, before we go to discuss more in details the cases and the status of the field, I'd like to summarize you shortly what is the special in the technology of the Cordis solution drug-eluting balloons. So this device is special in terms of the specific phospholipid coating, which enhances drug retention and optimizes the transfer of the so-called micro reservoirs. And what are these micro reservoirs? These are nice little bowls, spheres of sirolimus with biodegradable polymers, and as you can see here, it's mounted on the surface of the balloon. It's a polymer and the drug inside. And why is it important? It's important because this technology allows, the video shows when it's delivered to the spot where you would like to deliver the drug, these micro reservoirs get into the vessel wall, and they provide long-maintained drug elution. And what does it mean that it's long-maintained? It means that compared to some other devices, there is a much higher dosage of drug which really reaches the vessel wall. And even more importantly, if you look at the kinetic of this drug over time, actually it's more similar to the drug dosage in the vessel wall to the drug-eluting stents compared to other drug-eluting balloons. So why it's important? It's a very promising technology, and as Tom said, we are already taking the time in a couple of weeks, the data with the randomized trial will be presented, and I think we are all very optimistic, but this will be really the very first landmark trial in that kind, showing whether this kind of technology can be considered comparable to drug-eluting stent therapies. So we are waiting for this, and to spend our time with interesting topics, let's focus on some cases until we don't have this data. I would like to show you this case, and I have to admit right away that and this time we did not have access to the solution technology outside of the trial. So this case was done with another DCB technology, but still this case might present our practice for bifurcation procedures in our center. So our patient is a 78-year-old patient who presented with New York 3-4 status heart failure and acute coronary syndrome with elevated enzymes and elevated pro-BNP. On the echo, there was diffuse hypokinesia without valvular disease. And there are certain risk factors, including renal insufficiency. When the patient was sent to the cath lab, here you can see the anatomy. So it's the right is practically a CTO, and on the left side, what was recognized right away that the catheter is really wedging in the left main. And if we just a bit focus more on the left main, then we can see that it's a very tight ostium of the circumflex, of a large circumflex. The whole left main is short and tight, and there is also disease towards the LAD. So, summarizing, this is an unprotected left main with a CTO of the right, can be called Medina 111, quite unfavorable anatomy with a short left main and a reduced left ventricle function. And there was a clear consensus between the surgeons and the patients that they just want to be friends, but they don't want to see each other anymore. So no surgery came to the plan in this patient.
Pause at this point and reflect on all the discussions we've had in that last session around approaches to treatment, and a lot of that's wedded to upfront stenting and the considerations there. Beatriz, how would you approach this lesion? I know you haven't seen it, so sorry to put you on the spot, but what are your thoughts around this?
I think first predilatation, because there is a tight lesion in the ostial circumflex, and then imaging. And based on imaging, I plan the strategy. But it's true that this case is really not favorable to a stent, because there is not place to implant the stent, because there is is really difficult. So it could be a good option for another technology.
But on the one hand, we have an acknowledgement that stenting here has challenge.
Yes.
But at the same time, we have the most prognostically important lesion, where we worry then about doing things that are evidence-free. So in terms of approaching
but to me, implant here stent is a contraindication, because I have some cases and it's really difficult. If you implant the stent, for example, left main to LAD, it's really difficult to cross for the really proximal cell, and I have a really bad complication if you implant a stent here. So you predilate and with cutting balloon, according to the intravascular imaging, I think is the best scenario to do drug cutting balloon.
Okay. And Abhishek, you're going to tell us about LOVE DEB, but were left mains included in LOVE? Okay. Tell us what you're going to do.
Yeah, so we also try to have a plan in our mind based on the angiography. I mean, somehow we have to start a procedure. So our idea was more going with provisional towards the circumflex. Fully DCB-based strategy, I would say that this is far from our practice for an unprotected left main, not even for this case. And considering that since the jailed branch will be the LAD, and there is also disease, if one stent will be good enough, then we keep it for DCB. If not, then we might extend for a second stent. But we also know, based on this baseline angio already, that there is a certain challenge of the very short left main. So we don't know, or rather we have the impression that the proper potting might be challenging or rather impossible, risking a wrong wiring of the jailed branch. And there are certain unknowns based on the NGO, like the diameter of the left main, the diameter of the LAD and the circumflex, the extent of disease in the LAD. So I fully agree, as faint baseline IVUS will be the thing which defines for us the strategy at the end. But with this idea, we started the procedure. So we took a 7 French guide through 2 workhorse wires, and what we see towards the LAD, that there is indeed relevant disease, and as we get to the left main, it's really tight. And then if we come from the circumflex, we see a quite healthy landing zone, a very, very tight ostium, the circumflex, and the left main is just the same from the circ and from the LAD as well. So understanding from the imaging that the LAD is around 4 millimeter plus minus, moderately diseased, but diseased, the circumflex, the very ostium is diseased with the reference diameter of 4.5 with a good landing zone. The left main, the true size of the left main remains unknown behind the plaque, but we calculated around 6 millimeter. And the left main is extremely short based on the IVUS. It's maximum 3 millimeters, if at all. So we made a plan what we could do with this case, and considering that the pot will not be possible in this very short left main without risking compromising the jailed branch, and if we cannot do a proper pot, we risk false wiring of the jailed branch, which is in this case the LAD, and of course we don't want to jeopardize it. Our strategy for this case, and I can admit right away that this is not our standard strategy for left mains, but for the specific anatomy, specific conditions, we decided to do a kind of modified version of the sabot technique, not taking the very proximal cell, but taking the third cell in order to match the length of the left main and stenting towards the circumflex. So placing 2 wires, and in this configuration to position the stent towards the circumflex. So I can show you here how it looks outside. So you just pull this cover of the stent a bit more than the typical sabot technique, so just to have this around 3 millimeters of the stent inflated, then it causes this opening of the proximal part. You can put the wire behind that, so you advance your stent like this to the circumflex. The other wire is in the LAD, so you will advance it as far as you can, suggesting that this is really then the place of the carina, and then you inflate, and this is how it fit to this left main anatomy. So this is what we planned, and this is what we did at the end. We did lesion preparation towards the circumflex with cutting balloon and non-compliant, and then we placed the stent with having 1 wire behind the struts and the other wire is in the circumflex. We pushed the stent as far as it went, so really matching or the fitting to the carina. After that, we kept the stent balloon in place, and we advanced a small balloon to the LAD to open up the struts. Then we performed 4-5-4-0 kissing. In this case, it was with a longer overlap than typical. Why? Because this was supposed to do the job of the pot as well. And after that, we performed the IVUS in the LAD. And what we see, there was no major dissection in the proximal LAD. There are some certain neocarina. This is what this technique leaves behind. And there was a very oval left main, which is huge. And here you can see, as we get towards the ostium, there is some floating struts remain. So this is where, in our regular technique or regular practice, if we do a left main case and we decide for doing kissing, then we complete this procedure almost as standard with the DCB towards the jailed and non-stented vessels. So first we confirm on imaging that there is no stenting indicating say, complication of the kissing. And if this is the case, then we take the DCB for the side branch in that fashion that we park one balloon matched to the stented segment in the stent, and we take the DCB towards the jailed side branch. Very important that we are talking about as unprotected left main, and there is always the discussion whether you can inflate the DCB in the left main for the side branch. And I think for me, this is why it's important to do the PCI and put the stent first, because with this one, of course, we established already a huge diameter for the left main. So inflating DCB in the left main jailed branch continuum will not cause complete occlusion of the left main anymore. So you can mainly maintain the inflation for 30 to 60 seconds, even in such a patient with unprotected left main, reduced left ventricular function. And then the whole procedure is completed by pulling back these balloons and just low pressure inflate just to centralize the carina again. Here, you don't apply any more high pressures. This is really just to kind of fix the struts, which might be somehow deviated by the DCB inflation. So this is how it looked at the end. As you can see here, there is a small dissections towards the sinus, but there is good flow and good lumen in the left main. We left it for conservative therapy, and patient was discharged on day 2. And what is important, patient was called back for control angio in 10 months, which showed a very good result. Thank you very much.
Thanks, Gábor. That was a lovely result. The title of the talks was Simple and Safe, and I guess the reality is that is quite a complex strategy in the end, but for very complex anatomy.
Yes, but I would say that you could even make it even more complicated if you decide to go for a second stent because there is disease and LAD, and with this very tricky left main anatomy, if you have to convert to a 2-stent strategy, then you suffer twice from the complexity of the anatomy.
And the only other question that comes up is about maybe, do you have a systematic approach for the treatment of a side branch in this setting? So obviously in this instance, the side branch was the LAD that many people would never consider to be the side branch. But would you take a systematic approach in a sizable side branch of deploying a drug-coated balloon, drug-eluting balloon in a provisional approach?
So our practice nowadays in our center that in case where you decide to do a kissing, you have a good reason for that, right? And if you already did a kissing, you already dilated that side branch. So compared to that, to take on top of this a DCB and deliver some drug, it's an efficacy question. It's not anymore a safety question. If we believe in it, it works. We have to still wait to have it proven. But I think as soon as the kissing has been done, it's not anymore a safety question whether you want to bring drug there. And we had imaging confirmation there is plaque what you touch with the balloon, dilate the balloon. So I think we have a good reason to bring some drug there.
Okay. I'm just conscious of time. Should we get set up with your presentation? I wonder if there are any comments or talks. Thanks, Gábor.
Good afternoon. Thank you, Tom, faculty, the organizers, and especially the Cordis team for this privilege. I'm Abhishek. I work as a consultant cardiologist in Wigan, UK. Following on from that fantastic session on DCB and excellent presentation by Gábor, let me add to the mix our scientific endeavor with regards to the evolution of drug-eluting balloon angioplasty, or rather the revolution of it, with special focus on the value of sustained limus disease. And we'll finish off with a thought-provoking purist approach to treating bifurcation. This is my declaration. Our study focused on evaluating the safety and efficacy of solution, which is a sustained limus-releasing drug-eluting balloon in the setting of de novo coronary artery disease in large blood vessels only, and it was titled as Love DEB Study. I had the honor of leading the study in UK with my co-CI, Professor Zaman. In this study, which was prospective, observational, multi-center, we recruited patients across 9 PCI centers in UK, and I'm very grateful to each of the PIs for their overwhelming support. The patients who had undergone successful PCI, fulfilling the international DCB consensus group criteria, with solution drug-eluting balloon only in de novo large vessels, defined as vessel size 2.75 millimeters or more, were enrolled in this study. Ones with STEMI, cardiogenic shock, cardiac arrest, any prior revascularization of any vessel, patients who had left main bifurcation stenosis, CTOs, smaller vessels, and those who required atherectomy with mechanical devices were excluded from the study. The primary endpoint was clinically driven target lesion revasc at 30 days and 12 months. So here is the patient characteristics, predominantly male with a median age of 66.6 years, around 30% diabetics, and more than 60% with acute coronary syndrome presentation. There were 306 patients, 372 lesions from July 2023 to October 2024. Majority of these patients had type A or B lesions. The median vessel diameter was 3.0. Nearly 30% of them had bifurcation stenosis. The median vessel size was around 3.0. Most of these lesions were either proximal and mid vessels. Majority of these patients received single balloon with a median lesion length of 20 millimeters. In terms of the bifurcation disease, more than 90% had single bifurcation, and predominantly more than 80% of the patients had main vessel involvement. So in terms of the patient characteristics, the procedural characteristics, by no means these were sort of easy cohort of patients. So what did we find at 30 days? There were no target lesion failures, no myocardial infarction, no repeat revascularization. The 3 deaths were unrelated to target vessel involvement, and none of these deaths could be attributed to the index procedure. So to summarize the study in short, taking on board all the critiques which come with the non-observational randomized study, this is still a real-world multi-center registry with complex patient subsets. This is the first study with this novel sirolimus eluting device with its clinical outcomes, and at 30 days, there are no safety signals. We intend to present the 12-month follow-up data at a conference next year. We'd already presented this data at PCR, but we wanted to give a bit of a special flavor with regards to the bifurcation involvement. So next up is a case which was the first case recruited to this study at my center. So this is the story of a 63-year-old Asian gentleman with grade 3 angina, early positive exercise treadmill test, preserved LV function, diabetic, hyperlipidemia, and rheumatoid arthritis, which has sort of a pro-inflammatory effect, and the atherosclerosis. So this is his baseline angiogram. The cranial caudal views, LAD diagonal involvement 111. Just to throw it out there, let's have your thoughts as to how do you consider treating this. And I'll let the angiogram play for the sake of discussion.
Beatriz, I pick on you again. You mentioned earlier today that your colleagues seem to be shifting more and more towards a drug-eluting balloon strategy. Will you be looking at this lesion and thinking, I'm going to treat this with a drug-eluting balloon? Or how would you approach it?
I think in my center, the young operators, they do drug-eluting balloon in both vessels. They prepare with cutting balloon, and maybe for preparation they use intravascular imaging for vessel preparation and vessel size to choose the best size of the balloon. But then we didn't do intravascular imaging at the end. We follow only by angio, because here the diagonal branch is really big. It's a dual system. The LED is similar to the diagonal branch, and there is a disease that is maybe 10 millimeters in the diagonal branch. So is quite in the between simple and complex bifurcation lesion. So in my center, probably we do a drug coating balloon in both vessels.
And inverted Szabo technique into the diagonal?
No, but what we would probably do to do imaging to understand how far is the LAD, distal main branch ostium diseased, but this could be a case where you stand LAD diagonal and open LAD and use DCB for the LAD then. So we are not that far, not to take any stance, I think. But I would not hesitate to use the DCB towards the LAD and stand towards the diagonal, which has disease.
But it's fair to say that you would be preparing both limbs of this, regardless of whether you're going to be looking to do this by stent or by DEB.
Yeah.
Okay.
Okay, so moving on, what did I do? So first step is lesion prep. And the basics, as the experts would call it, is have an open mind about how the vessel behaves. So this is 2.5 NC just to get some flow down the vessel. And eagle-eyed of you will appreciate that there's a bit of dent around that segment in the both cranial views. But the 2.5 NC in the diagonal inflates reasonably well. So would you be happy at this point to deploy your drug delivery device, or would you consider investigating this vessel more? Sure. So this is the post lesion prep angiogram, if you like. It's a post POBA.
So there's murmuring
So is
in
it
the
good
audience.
enough for the drug delivery? Well, that's Peter said no, Helen said no, so it's a thumbs down. So what did we do next? We moved on to be more meticulous with the lesion preparation. So a 3-0 Scoreflex in the LAD seems to expand reasonably well. Slow deliberate inflations, checking in orthogonal views, followed by a 3.5 non-compliant balloon. Again, checking in orthogonal views, it shows uniform expansion. And likewise, a 2.75 Scoreflex balloon in the diagonal, which also seems to expand pretty well. Imaged it because of my concern with regards to the initial denting and at least understanding the degree of calcification is something else required for preparation of this vessel. But as you can appreciate, that there are arcs and rings of calcification which all seem to be reasonably well shattered, plus also further mixed plaque disease more proximally. So I'll let the IVUS run play thoroughly, and also it gives you the sort of extent and the length of the disease to appreciate. The left main or the LAD ostium appeared to be free of any significant disease. And the IVUS run was done both from the side branch and the main branch, and this run is purely LAD.
For the purpose of time, I'd move on.
Sure. So this is the post-prep angiogram. And looking at this angiogram, at this point in time, are some of you or most of you ready to place your drug delivery device? Or would you do something more? Well, there's no response. I take it that you're all happy with it. So now, at this point in time, it's important to consider the two approaches to treating or delivering the drug in the artery. One is metal, another is metal-free. And there are mechanistic and clinical advantages in avoiding layers of metal or layer of metal. Avoiding the pro-inflammatory processes, the issue of accruing event rates in normal non-bifurcation stenosis, but equally more pertinently in the bifurcation disease, and plus the clinical, the implications of it, where you can minimize and that becomes very relevant in this case later on, and leaving future treatment options open. So we went metal-free. Following on from Bruno's puristic approach, the side branch first, with a 2.75 solution and a LAD from the mid to proximal with a 3.5 solution balloon, and this is the final result. So we see that there is a rim of dissection, but good flow, less than 30% stenosis in this vessel, and TIMI-3 and patients hemodynamically stable. This is July 2023, 2 years since. The patient has been completely symptom-free, and the pertinence of the DAPT comes into picture because 3 months later he was diagnosed with prostate cancer, and that led to surgery. So implanting stent and all that does come into picture sometimes. Unexpected happens. So to conclude, as expressed in the previous session, there's no class effect with drug-coated balloons, whether it is paclitaxel or limus. Balloon, which is the sustained sirolimus eluting balloon, is a novel device which allows therapeutic delivery of the drug to the vessel wall and its permeation across the layers of the vessel wall, with the PK data suggesting that it is comparable to the best-in-class limus eluting drug-eluting stent. RCT and long-term follow-up data is on the horizon, especially the de novo study, and of course it will be paired with the ISR study at TCT. In our smaller, non-randomized observational study at 30 days, there's no safety signal, and gradually over a period of time, what we have come to realize that there's mounting evidence to go metal-free in various clinical scenarios, especially the more challenging lesion subsets, especially bifurcation. Plus, being metal-free offers mechanistic and clinical advantages as well. Thank you.
Abhishek, thank you. You put up a slide with a question mark and an exclamation mark. We've got Ben over there who's now glaring at me because we have run over time. So I think we're probably going to have to push discussion to the bar, but you definitely show a very elegant case which demonstrates the potential for what this technology might offer. But what struck me was really the care that you took in terms of preparation and the requirement to achieve a result. So let's see what Love shows us, what solution de novo has to tell us at TCT. Thank you to Beatriz and Gábor, and thanks to everyone in the audience. Thanks to Cordis for the support.
Thank you.